Hello everyone, my name is Wong. I'm one of the consultant cardiologists working in Princess of Wales Hospital. Thank you for the invitation, and today I would like to share with you about some updates on chronic heart failure management. The title that I want to share with you is Fantastic Four, Ironman and Agent K. This is my disclosure. Before I talk about various treatment in chronic heart failure, I think I would like to just mention a few important points about ejection fraction. Ejection fraction is one of the main determining factors when we choose pharmacotherapy in patients with chronic heart failure. The reason is ejection fraction was used in various trials as an entry criteria to test the efficacy of various drugs over many years. The current guideline recommended therapy is also recommended based on the evidence from these clinical trials. So we should be mindful that ejection fraction is a dynamic parameter. In other words, it is not static. Changes in blood pressure, in heart rate, changes in the loading condition of the patients, a sympathetic drive, any pre-existing valvular abnormalities of the heart, and all this can lead to significant changes in ejection fraction, even in a very short time span. So medication and cardiac devices over the years have shown the ability to improve ejection fraction in our patients. Younger patients and certain etiology of heart failure are more transient compared to the other one. So that may lead to an improvement in ejection fraction. However, on the other side, a low adherence to therapy, a poor compliance, in other words, to therapy, or reduction in this evidence-based medication can lead to deterioration of ejection fraction. Certain types of heart failure etiology, such as a big myocardial infarction with scar inside the heart and certain genetic cardiomyopathy, may lead to a less improvement or no improvement in ejection fraction. There is now a new classification for heart failure according to the patient's ejection fraction. So we are very familiar with this term heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Around 5 years ago, the ESC introduced a mid-range or mildly reduced ejection fraction. And not long ago, there's another classification called improved ejection fraction. So these are patients with the first echographic ejection fraction less than 40%, and with a 10-point improvement in ejection fraction with a subsequent ejection fraction rises above 40% are now called improved ejection fraction. The main reason to introduce this category is to encourage healthcare professionals to appreciate the beneficial effects of this guideline recommended therapy and reduce the unnecessarily stopping or reduction in these important therapies. In the last few years, there are various trials showing the beneficial effect of these medications to improve prognosis symptoms in heart failure. I call this a Fantastic Four. So what are these four drugs? Number one, angiotensin receptor nypiralizin inhibitors, in other words, Entresto, beta blockers, mineralocorticoid receptor antagonists, spironolactone or eplerenone, and recently we have mounting evidence to show these beneficial effects of this class of drugs called sodium glucose transporter inhibitors, dapagliflozin or empagliflozin. Instead of calling them Fantastic Four, a more conventional way to call this is called the Four Pillars of Heart Failure, a contemporary pharmacological therapy for heart failure with reduced ejection fraction. So the latest guidelines suggested that we should initiate these four drugs in patients with reduced ejection fraction of less than 40%. And these arrows, you can see the dotted arrows, it's just to show us about how many steps are required to optimize the dosing of these important medications. The 4 pillars of pharmacotherapy in heart failure, or the Fantastic Four, are recommended in national and international guidelines. Dr. Jenkins later on will share with us about the rationale and how we can implement this guideline in the management of heart failure. This is the key slide for my talk. Patient with ejection fraction of less than 40%, we should try our best to put them on Fantastic Four, or the 4 pillars of heart failure. So these guidelines has a class 1 recommendation to use these evidence-based drugs which improve prognosis in patients with ejection fraction of less than 40%. Whereas for patients with ejection fraction between 40 to 50%, diuretics is the cornerstone treatment. ACE inhibitors, ARB, beta blockers, MRA or ARNI, and all these agents, they do have beneficial effect on this group of patients, but less pronounced compared to patients with a lower ejection fraction. So these agents can be used in a patient with ejection fraction between 40 to 50%, even on a higher ejection fraction. Whereas a patient with ejection fraction of over 50%, we should assess whether the patient is congested and use diuretics accordingly to relieve congestion in this group of patients. So of this group of patients often has many comorbidities, which we should try to optimize the management of these comorbidities, such as sleep apnea, diabetes, CKD, anemia, COPD, and so on and so forth. A patient in this group with angina, with coronary artery disease, we should also consider revascularization. In other words, coronary intervention to improve circulation around the heart. In patients with sinus rhythm, with polyvascular disease, with carotid disease, peripheral vascular disease, and coronary artery disease, we can consider adding low-dose rivaroxaban in addition to aspirin, based on the COMPASS trials, to show that there is an all-cause mortality benefit in this group of patients with mild to moderate heart failure. So across patient with ejection fraction, based on the Ironman trial, there is a potential benefit to use intravenous iron to reduce the risk of rehospitalization and also improve the patient's symptoms based on previous trials as well. Exercise obviously is very important regardless of the patient ejection fraction, and we should encourage patient to exercise and refer the patient to a heart failure rehab program whenever possible. In recent years, we have now got evidence to suggest the use of SGLT2 inhibitors, dapagliflozin and empagliflozin across the ejection fraction spectrum. In other words, patients with heart failure, regardless of the ejection fraction, SGLT2 inhibitors would have a beneficial effect on this group of patients to improve outcome. My title is Fantastic Four, Ironman, and Agent K. So what I'm going to tell you next is about potassium binder, a K binder. We've now got 2 novel potassium binders that we can use to overcome the problem of hyperkalemia, particularly in patients with chronic kidney disease, with coexisting diabetes, to allow us to optimize renin-angiotensin-aldosterone system inhibition therapy. Our local data has suggested that this approach is feasible and is very effective. There will be a trials coming up called the Realize K, which is going to assess the real clinical benefit in the trial setting. I've told you now the Fantastic Four, the iron, and also the potassium binders. The following are the 2 drugs that you may see in the next couple of years that potentially can be used in the treatment for heart failure with reduced ejection fraction. Number one is called vericiguat, which is a soluble guanylate cyclase inhibitors. And the other one is called omecamtiv mecarbil, which is a cardiac myosin activators that improve contractility of the heart and is particularly useful in patients with a lowish blood pressure who otherwise have difficulty optimizing RAS inhibitor therapy. And the other agent that I want to mention is a non-steroidal mineralocorticoid receptor antagonist called Fineron. Fineron has been shown to have a kidney protective effect and improve outcome in patients with diabetic kidney disease. From these trials, a subgroup analysis have shown that it is also potentially be very beneficial in patients with heart failure, and the dedicated heart failure trials are awaiting. So these drugs have shown to not just to protect the kidney, but also less likely to cause hyperkalemia. So watch out for those agents. And lastly, I just want to mention briefly how the outpatients heart failure clinic in Princess of Wales hospitals are run. So in essence, a very complex patient with very high NT-proBNP, in patient with lots of comorbidities, we try to manage it in the hospital. In recent years, we have trained our pharmacists in our hospital and also in our cluster GP clusters who are a valuable asset to help us to optimize heart failure medications. So more straightforward patients with good blood pressure, good kidney function, less complex patients will be managed in our hospital in the pharmacist-led clinic and also in the community in the pharmacist-led clinic for optimization of the heart failure therapy. And our pharmacist colleagues have also got the option to dial into our weekly MDT for education and also to discuss cases and to troubleshoot. Ladies and gentlemen, this is my last slide. Thank you for listening to me, and I hope that I give you a good overview about pharmacotherapy and what to watch out for in the coming years in terms of the treatment, pharmacotreatment for chronic heart failure. Thank you very much.